Hello everybody and welcome to the Bad EM podcast. My name is Daniel Still and I am your host. Bad EM stands for Brave African Discussions in Emergency Medicine, and this is a platform we use to try and find African solutions for African problems. In this month's episode, we are talking palliative care in the emergency department. How can applying palliative principles early and effectively make the lives of the patient, the family, the carers, the doctor, and the whole healthcare system exponentially better? Some may think that emergency medicine and palliative care don't have much overlap, but I can guarantee you that by the end of this episode, your daily practice will change regardless of what type of medicine you practice. Whether that's inpatient or outpatient, whichever department you work in, whether you're a doctor in a different speciality, if you're an emergency doctor, a nurse, or if you work in the pre-hospital world, basic palliative care principles can be and should be applied by anyone. Our guest this month is Dr. Kat Evans, who's actually one of the founding members of Bad EM itself and is one of the drivers behind this podcast, so we have a bit of home ground advantage for this episode. She is an emergency physician with a special interest in palliative care, as she will explain further along. This month, we are also doing something a bit different. We have incorporated an interview that Kat did last year with the Case Report podcast with Dr. Callum Smith, where Kat explains the fundamentals of palliative care in the emergency department. So we'll start with that, after which we'll move to how good palliative care can benefit doctors in the system in general. The link to the full interview is in the show notes, and thanks again to them for all the other wonderful content they make, and you should definitely check out. As always, views expressed represent myself and my guests in a personal capacity and do not represent any organization that we represent. So without further ado, welcome to the show, Kat. Would you start by introducing yourself and giving us a brief background of your professional career so far?
Cool, thanks so much for having me, Dan. I'm Kat Evans, a specialist emergency physician. I am originally from Durban. I worked in EMS for a couple of years and subsequently went to medical school, qualified as doctor and came to Cape Town for internship and never left. So I was intern in a GF Jooste hospital and ComServe, subsequently Mitchells Plain. And I've been working in the Mitchells Plain district essentially since then. I specialize in emergency medicine, finishing in 2015. And from then until now, I've been a consultant at Mitchells Plain Hospital and Heideveld Hospital emergency centers. And I have a special interest in palliative care. I've did a postgraduate diploma in palliative care in 2019, and I'm currently doing my PhD in emergency medicine, but with a palliative care topic. So that's my background.
Awesome. Thank you, Kat. So now I'm going to play an excerpt from the Case Report podcast, which gives us a really good idea of what palliative care in the emergency department actually is, after which we'll come back and chat about the broader topics revolving around how palliative care can affect systemic change. Over to Callum at the Case Report.
It's quite an interesting niche, or not so much of a niche, but an interesting special interest, palliative care. And I was wondering what got you into it to start with.
My interest in sort of the palliative care, palliative medicine, emergency care overlap started when I was in EMS. So before I was a doctor, I worked in EMS in Durban. Working in EMS, you get called to a lot of people's homes in times of crisis, and quite frequently there you have patients that are clear-cut palliative care patients, either at end of life or with some kind of a crisis. EMS gets called because the family is afraid, because there is some unanswered questions, and learning to sort of do things different to the sort of ABC approach was important. And I sort of started to see how our protocols and our guidelines and the way we do things doesn't really work for that group of patients. But often the only way, especially in a resource-limited environment, for those families to access help or care in 2 a.m. is realistically with an ambulance or to an emergency centre. And there's very limited access to 2 a.m. palliative type services. I think that's where it began, as going to those homes with families or patients in crisis.
That's really interesting, because I remember in the induction pack when I started working in Mitchells Plain, there was a whole section on palliative care, and the way you phrased it was, I found really impactful. You said, when someone who is clearly at the end of their life comes into the emergency departments, we have to consider that our time might be better spent doing a different type of approach and focusing on things like bringing family in and making the patients comfortable and dignified rather than our typical ABCDE resuscitation lines, x-rays. So it's still active management, but it's a different kind of active management. And that takes a little while to get used to, I guess, because we're drilled into the same structure for everyone who comes into the ED.
We often spend so much time doing those other things like getting the blood culture and putting in the IV and doing those things that we actually don't do any of the important stuff, which actually makes an impact for the patient and the family. They end up admitted and will sometimes go home, and then they come back again 1 week later and the same thing repeats itself, and we haven't had time or capacity to have the more important conversations.
So how would you define palliative care, especially in an emergency medicine context?
So I think what's important is a lot of people feel like you must do stuff, you must do things. And so when you're looking at emergency medicine and palliative care, a patient with palliative care needs should be seen just the way as a patient with critical care needs, in that it's not the absence of care. And I think that's where often healthcare workers can misunderstand, or they'll say, oh no, that patient is just for palliative care. But what they're actually saying is that patient's for nothing. And that's completely the opposite, actually, of what they need. So they'll say, oh no, that patient's just for palliative care. Oh no, that's just a palliative care patient. And that's why we aren't taking the patient to resus and doing these things. But then they're not understanding that that palliative care is an active process. And the same as we say to the families, or sometimes we don't say it in so many words, but that's how the families hear it. The family gets told the message, there's nothing more we can do, which is actually not true at all, but can be the most hopeless thing ever said to someone. If you hear the words, there's nothing more we can do, what the family visualizes is this person is going to suffer and flail and be confused and restless and in pain and whatever. What we mean is we can't provide curative care anymore, but what they hear is something very different. So I think it's to try and get that messaging across, and that palliative care is an active process, that we can do a lot. So I rephrase things differently. As I say, we're not going to be able to cure your mum's illness. We're not going to get rid of the cancer or whatever the problem is, but there is a lot that we can do to make things more comfortable, more dignified, and provide comfort.
Yeah, it's such a fundamental rethink in how we phrase it. And I love you've got a pre-printed palliative care drug chart in the departments, and on the opening page, in where usually the nursing instructions go, there's a kind of pre-printed thing with the focus on care, and it's all active things. I wonder if you could just read them out for us.
Sure, I've got it here. So on the front, where we would traditionally put the sort of intravenous fluid prescription and the meal status or whatever, at the top the heading is focus of care, and we've divided into 4 sections, which is the 4 arms of palliative care, actually, which is physical, social, psychological, and spiritual. So number 1, we've put physical. Ensure patient is kept comfortable and pain-free. Treat pain by adjusting morphine infusion. Treat restlessness with sublingual lorazepam. And do not perform painful or uncomfortable tests or interventions. And then it's number 2, social. Allow visitors as per palliative care visiting policy. So that's one of the things we worked on, is changing our visiting hours policy for palliative care patients. Number 3, psychological. Ensure patient is supported emotionally. Number 4, spiritual. If patient or family wishes, allow religious representative to visit. That's put actually under our orders, where you would traditionally put the intake-output instructions, etc.
One of the challenges I find as a training doctor is identifying patients that need palliative care when they first come in the door. You often don't have all the information. You might suspect that they're in the process of dying based on their age and their comorbidities and the disease process that you think is going on, like a pneumonia or an intracranial bleed or something, but you might not have spoken to all the family yet, so you're just gathering records. I wonder what your approach is to identifying the patient that needs palliative care rather than active resuscitation.
We know that as doctors, we are very bad at recognizing normal dying. This is 100% true. We are terrible at it, at recognizing normal dying. I'll give an example that happened to me probably a year or so ago, as I walked outside the ambulance entrance to make a phone call. And there was a family member who was also on the phone at the time. And I knew the patient was inside. And she was on the phone, and she said she was talking to her loved one sort of pacing up and down outside our resus room sort of entrance. And she said, we thought that whatever his name was dying. And so all of us, the whole family, rushed to hospital when the ambulance came and fetched him from home, and because we thought he was dying. It turns out that it's actually just his blood pressure super, super low, so they've put him on medicine to bring his blood pressure up, and it's also his oxygen levels are really low, so they've put him on a machine just to help bring the oxygen levels up. They now say that he's stable, and that's so. Sure, we actually feel a bit bad now. We all rushed here because we thought he was dying, but it turns out it's just his blood pressure and his oxygen. And I thought to myself, how did that communication go wrong? Because I know this patient is most likely going to die. And that's what the family recognized. So the family recognized dying. And then however we've communicated, our part has told them that they actually were wrong. And they're not wrong, they're right. So sometimes family are quite good at it. And I can actually sometimes get this from family. If you start to learn communication tips is when you get your history from the family is, how have things been the last few months, the last few weeks? What do you think is going on? Why do you think he's getting like this? And you'll be surprised how many families, when you ask, why do you think this? Why do you think that is? And you keep on asking those questions, how many of them actually say things like, doctor, I think it's probably the end. And you'll be surprised how many families are able to say that because they're able to see how things have changed with time. And when families say things like that, again, they're probably right, and we should probably be getting on the same page as them. And they are, when they say it out loud, that's often the first time they've said it out loud, and they're like, actually, I think that this is what's going on. I think he might be the end now, or they'll ask you, doctor, do you think now it's maybe near the end? But often you can get that from the history if you actually unpack it with people. Obviously, that doesn't apply to an acute sudden illness in someone that was previously well. But I think we see palliative care kind of patients or patients that are eligible for palliative care in three main groups in our department. The one is the known palliative care patient that comes in crisis-driven. There's a crisis for some sort, whether it's spiritual, existential, pain, symptom control, social crisis because of care or loss of care by family or circumstances changing at home, or the loss of supported devices. A peg has come out, or where this has happened, medications run out and they haven't got the safety net to get more. That's the one group. So it's sort of known palliative care, and those are crisis driven, and we just need to figure out what the crisis is and help them come up with a plan for the future crisis that will arise. The other group of patients is patients that no one yet has realized does have palliative care needs, and therefore they're coming to the department the whole time because no one has linked them with appropriate services and identified that this patient needs palliative care interventions, and or communicated to the patient as such. Sometimes the family are bringing them every 2 days because no one's adequately communicated that this is the expected trajectory one can expect. And lots of families, they send you thank you cards and little chocolates and little sweet to say thank you because you're the first doctor that's ever told them that, this is her body slowly shutting down and this is what you can expect in the coming weeks, months, they're very appreciative of that. They're like, we keep on bringing him back the whole time because he keeps on getting worse and worse and no one's doing anything. And it's because no one's probably communicated that this is an expected trajectory. We just get frustrated and label them frequent flyer or something like that. And then the third group of patients are acute, sudden, that don't really fall into palliative care. It's an end-of-life scenario for whatever reason, a massive intracranial bleed, stroke, unsurvivable, cardiac infarct, or unsurvivable extreme multi-organ failure, sepsis type picture, or as you've experienced this week, burns, massive burn wounds, 100% burns. So those are my sort of three categories of patients that come into the department.
What language do you use when you're telling a patient's family or a patient that they're dying? Do you use the word dying? Do you allude to it, or are you kind of direct with your language?
It depends if I'm dealing with patient or family. In the emergency centre, we end up less with patient and more with family, majority of the time, because of the patient's ability to comprehend information, and that's due to the pure nature of what type of problems bring patients to the emergency centre. Using the word dying, die, will die is key, and it makes a huge impact And family are often very grateful because that's what they were quietly thinking was going on, but they're uncomfortable to say it out loud, or they don't want to sort of say, if they say it out loud, it must be true. There's that kind of thing. The other big common phrase I use a lot with families, even if I'm still on a curative journey, but I'm worried that we're going to head in a different direction, is that if you as a doctor think that there is a chance this patient might die, you should have the respect to the family to tell them that. Because how many times doctors are super worried about a patient, they're really, really sick, they're struggling, they're this, and they don't tell the family there's a chance they could die. And I say, why didn't you tell the family that in your conversation? And the doctors will say, well, no, we're still busy with this. We're still giving the inotropes. We're not like stopping the inotropes. Then I'll tell the family. And I'm like, if you're so sick that you need to be intubated and get inotropes in the emergency department, that is seriously ill. Let's be realistic. There is a very good chance. We hope not. We're working hard to try and not let that happen. But you should say that to the families. So the way I say it is I say things like, I'm really worried about your brother. Because what you want is the things that you say to the family, they need to be able to repeat it to their extended family. So when you say things like, oh, we're going to give some medicine for the blood pressure to bring it up, that's inotropes, right? We know that, but they don't understand that. That's just like a blood pressure medicine for them. That doesn't mean anything. So, but when they say on the phone, when they're phoning the family afterwards, they say things like, the doctor was really worried. The doctor says he's really, really sick. The doctor's worried that he's so sick that there is a chance he can die. I mean, it's true, right? He's so sick he can die. That's the whole reason we're giving them inotropes and we're tubing them when we're doing stuff. He's so sick he can die. And I use the words, I am really worried, which allows the family to repeat on the phone to their loved ones, the doctor's really worried, as opposed to the doctor says he's stable, which means nothing to anyone. Anyone that's had a phone call about a relative, someone phoned me, a nurse from an ICU once phoned me to say, Gran's just arrived to hospital, she's been admitted to ICU, but don't worry, she's stable. As a doctor, when you get a message that your Gran's in ICU, but don't worry, she's stable, you know that could mean anything under the sun. Like that literally is not a helpful piece of information, and that's for you as a doctor. So I think it's just, those are the kind of language I use. I do use the word really worried he might die, really worried that there's a chance. And you know what? If that patient does survive, well, guess what? You're the best doctor ever. The family will be incredibly grateful. So no one will be angry with you for saying that because people say, well, what happens if he survives? And you said that he might die. I said, yeah, didn't say he was dying. I said, he's so sick he might die. And the family are all very grateful, and they might even bring their loved one back back with the balloon or the flower or the whatever to say thank you. So I think that's important, is that if you wouldn't be surprised, if you went off shift and you went home and the next day you came to work and someone told you, oh, do you remember Mrs. Smith? She actually died this morning. If that doesn't shock you to your core, you should probably be telling the family. So that's my sort of way of thinking about it.
Do you take the family's will and desires about their loved one's care into consideration when deciding whether to apply palliative care or not, or is it your clinical decision? Obviously, it's nice to have the family on board, but is it independent of their wishes?
Things are very different in different countries, how things work. I mean, in the States, it's sort of the family make the decision about everything until the patient's 122 years old. It's. I think what's very important is how you communicate that, because if you shared decision making. There's certain things that we can and can't do in state sector. If ICU is not going to accept a patient, they're not going to accept the patient. The family can wish it all they want. It's not actually an option. But I think it's very important when you think about shared decision making in emergency medicine. I mean, shared decision making in emergency medicine is a really big thing, and it's a real skill and an art into things. You should never offer something that is ridiculous. I'll use an example that's not palliative care, but it's an emergency medicine thing. Is you've got a child where you're on the fence. Should I do a lumbar puncture? Should I not do a lumbar puncture? This is like borderline. Is this a meningitis, or can this kid just go home? Like, is this a viral upper respiratory tract infection, or is this actually a meningitis that's bacterial? And if you as a clinician are on the fence, you really think it's fine either way. Either they could go home and watch the kid at home, and if they're getting worse, okay, fine, come back. Or you could do the lumbar puncture, and both of those options are reasonable options. Then the principles of shared decision-making are appropriate. And then you involve the family in that decision-making, weighing up pros and cons. But if you've got a child with a profoundly stiff neck, with every clinical sign of a severe bacterial meningitis, that's not a shared decision-making scenario. Like, you don't give the parent the option to take the kid home and see what happens. It's ridiculous. So the same should go for doing, resuscitative interventions. You shouldn't offer something that is completely ridiculous, that would be out of line with everything. 98-year-old patient with advanced metastatic cancer. You don't say to the family, because by offering things to people, it implies that you as a doctor think that this is a reasonable option. And that's important, is that you're almost giving your recommendation. By offering something to a family, it's almost like you as a clinician giving a recommendation. You ask the family, would you like us to resuscitate her? They actually didn't know that was an option until you've offered it. And they were like, oh, you can resuscitate her? Like, we sort of didn't know that's an option. Yes, completely. Yes, we want our gran back. What they might mean is they want gran that was, from 2 years ago back. That's what they want. But that's not how you communicate. So it's very important not to offer a shopping list of things. So people sort of tend to go down this list. Do you want CPR? Oh, that's an option. You could just do CPR and she'll just come back, just like that. Do you want this? Do you want this? Do you want? So rather than going down a shopping list of what things you do and don't want, you should rather be trying to elicit what's important to the people and family. And so going through, okay, what's important to her? So I might say things like, your mom, I've never met your mom before. I'm an emergency medicine doctor. I'm not a GP. I don't see these patients, they're long term. So I'll say, I never met your mom while she was still, the way that she was 2 years ago. I never met her. So I don't know what kind of person your mom was. What do you think your mom would say about the current thing, like her current health status and how things have been going at home? If mom was sitting with us now, what would she think? So I start to go through with them what mom would say in the situation, rather than a shopping list. Okay, what do you think mom would think about her health? What do you think mom would think about what's going on? That kind of thing. And I try to elicit, if mom was with us now and could talk nicely, what do you think would be important to her right now? What do you think would be her priorities, or what do you think would be this? And I try to elicit the goals of what's important to them. And then once we've established those goals of what's important to them, then I go the next step and I say, okay, it sounds to me like it's very important to mom that her family's around her, because her family was a very big, important part in her life. And okay, it sounds to me like mom would be very unhappy with the kind of pain that she's in now, so treating her pain would be one of the most important things. And that sounds like, as a family, you're very distressed by the pain or the thing that she's in. So I go that way around, rather than starting with, do you want this ridiculous thing? That then it's really awkward, because what happens when the family say yes? And you're like, oh, we're still probably not going to do CPR on this 98-year-old lady with advanced metastatic cancer. Now you're in this awkward, weird position. How do you backtrack from there? So I start with goals, and I work towards, then I create a list of things that we are going to do to meet those goals. And we don't necessarily bring up the CPR and the resuscitation, because it is inferred by the goals.
I think that's an absolutely brilliant approach. And I've definitely heard terrible approaches where the opening thing is, if your grandma's heart should stop, would you like us to restart it? And they go, yes. And then you tick for max resuscitation and on a 90-year-old, and it's ridiculous.
A lot of people think, oh no, we don't have time for all of this in the emergency centre. That's like the number one thing I get. But when you get practice these kind of conversations, to be honest, this is an under 15 minutes, sometimes even under 10-minute conversation. If you start with, I've never met your mom before. I don't know what kind of person she was. Tell me about her. Tell me about this. What would she say about this? This is actually really quick conversations, but people think that this is some sort of 3-hour seminar with the family or whatever. It's actually often not. It's actually often super quick. And often it's the family that does most of the speaking and not you, and they come to their own realizations. And sometimes there's family that say, maybe we actually shouldn't have brought it in today. Now that we think about it like this, and you've said nothing. You've just helped them to, think out loud and to reaffirm. And other things is just congratulate. It's really tough. It's really tough looking after someone that's dying, and just congratulating them for doing a good job and saying, we see you, we know this is incredibly hard, like you are doing amazing, well done, and how can we support you? And sometimes they've come to hospital because there's a dispute between family. We talk about, the sister came from Johannesburg, which is another city in Cape Town. And everything's been going fine at home. Everyone has got everything. But then the sister comes from Johannesburg, hasn't seen mom for 2 years, and suddenly we're at the emergency department. And it's because everything was going fine, and then they suddenly feel like a bad daughter. Maybe I should have done this. Maybe I should have. And sometimes all that they came to the emergency department for is for affirmation that you're doing really well. Well done. Keep up the good work. How can we help support you more? What do you need from us? Do you have any questions you want us to answer? But because they come with abnormal vitals and a high temp and this, then suddenly they're down this whole pathway that was not actually why they came. They sometimes just come because they've got questions about the noisy chest or a wound, or is this okay that we're giving this medicine that we actually got from my cousin? My cousin's on these sleeping tablets and we were giving it to mom and it actually really helps her. And sometimes you're like, that's okay, we'll write you a script for the same stuff, and it's simple things.
Brilliant.
All right, thank you, Callum, and welcome back to 2024, everybody. That interview was from last year, and you can find a link for the full interview in the show notes. Now to move on with Kat. So there is good evidence that palliative care can be cost-saving. How can we practically apply good, early and efficient palliative care-orientated decisions in a South African healthcare context?
Yeah, I think there's it's internationally very well recognized and understood that good quality palliative care overall does result in health saving for the system, cost saving for the system. There's many different ways about this. There's a sort of very emergency medicine example of the patient with an acute, sudden, major event, like a massive burns, for example. Early recognition of interventions being futile can be quite important and helpful, and can actually help with the moral injury of staff involved. For example, a patient with 95% full thickness burns arrives to an emergency center brought by family or brought by BLS EMS crews, and you sort of taught this ATLS approach to this. But if you understand that in the health system, really across the world, but especially in our health system, that a burn like this is providing interventions, aggressive, curative, focused interventions would be futile. Starting excellent quality end-of-life care from the outset is very important and can definitely result in a cost saving. There's the cost saving for pure rands and cents, but don't forget the cost saving in the human time. A patient with a 95% burns, if people go and do a rapid sequence intubate that patient, do extensive scrubbing of all of those burn wounds, apply expensive wound care products that can cost tens of thousands of rands just for a single application to one patient of a burn of this size. And the time cost, if you only have 2 doctors on duty and 4 nursing staff, and all 6 of those staff members are required to be there, the time lost also for other patients is important, whereas providing acute, rapid, good quality end-of-life care, family counselling, and pain control and sedation, where appropriate or where needed, is overall a cost saving, because people will pour a massive amount of human resources. Often our financial situation is often a human resource problem rather than a pure rands problem. The other sort of scenarios that we'll often face, we've spoken already about the groups of patients that come to the emergency centre that have palliative care needs, but the one are patients who maybe aren't really known to us. They might not have come to our facilities before, but it's the patients with very poor baseline level of function. I quite like the frailty score and trying to understand people's level of function, and really unpacking what that level of baseline function is helps you to determine what the next steps are. And it's often something that's skipped in the emergency centre. I think COVID taught us to start looking more at the frailty score, start looking a little bit more detail about what is the baseline actually. And I think sometimes spending some time with the family, understanding what the baseline is, helps the family to also acknowledge this. And I go back sometimes and I make the patient as best as possible. I say, when last did she leave the house on her own to catch a bus without anyone going with her to wherever? And sometimes the family is like, wow, yeah, actually it's been like 5 years since we would have let her take a bus anywhere on her own. And then I slowly bring that baseline. Rather than the other way around, some people start at the bottom and they say, does she wash herself? Does she do this? I sometimes start from the other end, which is the excellent baseline, and work my way downwards and say, when last did they do this? When last did they do this? And I work my way slowly down to reach the bottom. I think it just gives the family some more time for introspection. And when you get in your history, you're taking a history, you're examining your patient, doing necessary tests, the sort of normal process we go through in hospital sort of medicine. You getting that baseline level of function is often not done. It's just not done properly, and it changes your entire pathway. And so often people have done a history without including the baseline. They've done an examination, they've started some tests. Then the consultant comes along and asks, but what's the baseline?
I find that a lot of doctors, wherever I've worked, including myself, and I've learned this over the years, you have to ask detail about baseline. Often people will say, what can she usually do? Something like that. And it's very vague. And then the family will say, oh no, she's fine. She's like normal. But then when you ask more specifically, like you say, can she leave the house alone? Oh no, she just walks around home. Can she make her own tea? Oh no, we don't actually let her touch hot things in case she burns herself. Can she walk to the bathroom? Yes, she can walk to the bathroom. And that's very different from, oh, she's fine.
And then when you have properly understood someone's baseline, you can really, that guides everything you do here and out. And I think I just want to reiterate this again. I've probably said it earlier on, but just because you've got the label palliative care does not mean that you must never come to a health facility again. And that's often some of the perceptions from certain in-hospital disciplines is like, oh, you've got this sort of label. No, you mustn't come to hospital again. But quite frequently, there's many appropriate admissions. And sometimes there's a point when we reach where, okay, we've treated your pneumonia, you're going home, your baseline is slowly worsening, and the conversation needs to be held that, okay, she's going home today. There's a very good chance she's going to get pneumonia again because of her swallowing difficulties and this and whatever. We've treated it now with antibiotics, but if this happens again, she gets another pneumonia, the antibiotics are going to likely to work less and less. And possibly we can consider if she gets another pneumonia, that antibiotics wouldn't really do what we need them to do. They're not going to bring her back to her normal self again. And maybe next time she gets a chest infection, we're going to rather keep her comfortable at home and not necessarily admit her and do those things. But having those conversations in advance, not when she gets the next pneumonia, can sometimes be quite helpful. Just starting to paint that picture of what does the future look like. The other big thing, I don't know if it's going to come up or if it's going to come up in our questions to follow, is communication with patients and their families, and what can they expect? What does the future look like? And I can't even tell you how many people with advanced dementia or advancing dementia, where no one has told the family that this is normal, that what we can expect slowly but surely, she's going to be in bed more and more, she's going to get out less and less, she's going to talk less, she's going to eat less, she's going to drink less. And at a certain point, she might become poorly responsive. And while I'm putting it very crudely, like this, there's more gentle ways to explain this. Often no one's told them that. So they keep coming back to hospital because No one's told them that this is what we can expect. Another sort of more hospital-based acute emergency medicine example is the dead leg. So someone has got critical limb ischemia. Conversations have been held between the surgeons and the patient's family and the patient, etc. And long story short, the decision is made not to amputate. We're going to focus on comfort and not going to amputate. Probably going to die in theatre, might not die in theatre, might die post-operatively. Basically, the amputation is not really going to help this particular patient. Not to say that we never do amputations on patients' palliative needs, but this decision has been made. Family go home. Everyone is happy. They've engaged this. They're fully on board with the whole treatment plan. They agree with the surgeons. They go home. They come back to EC 1 week later, and everyone's sort of sighs. Why is this patient here? This patient was discharged for palliative care, blah, blah, blah. Why are they back? And you speak to the family, you say, what is worrying you? What's this? Oh, no, we know about the leg, doctor. We know, we agree. We didn't, because everyone's like, what? Last week it was decided that she wasn't for amputation, so why is she back now? No, we know, we're happy. We know about the leg. We're not here because of that. We're here because she's confused. We're here because she's breathless. We're here because of the chest. The chest is noisy. We're here because of the confusion. And everyone's like, yeah, but isn't that what, happens? But no one's told them what dying looks like. And when you give people information, they can then that'll help to guide their decision-making, what they want to do. I talk a lot about anticipatory prescribing in palliative care. So you often need to prescribe not for the symptoms today, but for the symptoms that are going to still come. So someone's going to be at the house, and that's their plan. It's been discussed in great depth that they want to be with their family, they want to be at home, and their symptoms are beautifully controlled today, and you send them home. But you can reliably, like with a dead leg, predict that they're going to get restless. The pain is going to get worse potentially. They're going to develop breathlessness, etc. And you haven't given the family the tools to cope with that, whether those tools are emotional, whether those tools are someone else to help, whether the tools are the medication that they might need when they reach that point, then they're going to come back. Because where else must they go to for help if you haven't linked them with someone that can help them? And this comes down to what we said at the very beginning of the interview, is at 2 o'clock in the morning, where do you get help? Where do you get help? It's as simple as that. Your mom is in front of you. She is restless. She's in pain. She's suffering. She's whatever. You know that she's near the end of her life. You don't know when that exactly is going to be. You know that she wants to be at home, but you can't see her like this. And if you don't have a phone number of someone to call, then, well, guess what? You're going to come to the emergency center. And it's because you care about your mother and you want someone to do something. That something isn't necessarily a cure, but what we hear as emergency center staff, we see them coming in, and some people will sort of roll their eyes, be like, well, what do they expect from us? Well, they often what we think they want. We think they're bringing her back because they now want us to fix, but actually they want us to care.
I think that's a good point to move on to pre-hospital systems. How do you see EMS services getting involved in palliative care needs?
It's a really, really good question. There's some amazing literature you can read. As a paramedic, his name is Caleb Gage. He's doing his PhD on this topic through UCT. I'll give you the articles afterwards. You can link for the listeners to read. Essentially, in my context, I speak very much from a government sector context. That's low resource, low income community, government healthcare context. How EMS fits in my mind now, obviously I am not an EMS provider. I have been in the past. I was before I was a doctor. But EMS doesn't matter how amazing, phenomenal palliative care systems are out there, people will phone an ambulance at times in a crisis. Because dying can be scary, can be terrifying. Doesn't matter how well prepared you are.
Even with the best communication, with all the principles you've spoken about, come to the crux of it at 2 a.m, it's very scary for the family to experience.
Yes, it is what it is. You can do everything perfectly. There is a percentage of patients that doesn't matter what systems are in place and what services exist and how they're being supported, there is a certain percent of families, can't tell you what that is exactly, that will phone an ambulance at a time like this in a crisis. And you've got to accept that. It's not some sort of failure of the healthcare system if an ambulance is being called. So if you acknowledge that fact, that sometimes that's just fear and they need help, and that's the way to get it. Now, there's a lot of places that propose the integration of advanced palliative care into EMS. There's a lot of places that have done amazing projects involving EMS and palliative care. I'm on the fence in certain areas. Yes, there needs to be an understanding of palliative care as a concept. There needs to be some principles taught, integrated into curriculums and things, especially at advanced level. But that being said, some of the courses are shorter. You can't have 6 weeks of the curriculum being palliative care. So there's a balance to be had. I think what often happens is that EMS teams will get to a house, they will recognize this is a palliative care scenario, okay? And then there needs to be some things that exist. First of all, it's still complicated from a HPCSA point of view. The sort of, in inverted commas, discharging patients on scene thing. It's like from a scope of practice, various things, there's complications in that area. I'm sure things will change with time.
Especially if there's documentation already and the family has that sort of clarifies the decision-making capacity.
Yeah, I mean, again, we've got to give EMS the tools to work with. If there is no advanced care plan developed for the patient, if the hospital haven't taken the time to put together a comprehensive discharge letter with detailed instructions that the family have, been engaged with, and it's very clearly, nicely written out of what to do in time of crisis, etc., then it makes it very hard. You're not giving EMS the tools to work with because they get to the house, the family's in crisis, no one can tell them nothing, everyone is crying, there's no forms there, there's no discharge letter that explains that this lady's been discharged home for comfort care at the end of her life. Like, there's nothing that's been documented or explained or anything.
Yeah. Pneumonia admitted, given antibiotics, discharged.
Yeah, discharge follow-up clinic 1 week, How can EMS work with that information? The next thing is, so EMS do get to a house, and it's not necessarily end-of-life situation, but there's some sort of thing that they pick up that this patient, the family don't actually want to go to hospital. This is a palliative care scenario. Maybe the person's bedbound or frail or whatever, but they pick up that there's a need here. So what is your system? What has your hospital done to give the EMS, the tools to manage? So this doesn't now mean that EMS must be palliative care providers and drive around providing palliative care. So if they pick up something, who do they refer to? So in our district, we're by no means doing things perfectly, but EMS in our district know that there's a handful of us that are sort of champions, as it were, and I'll get these little stickers or notes under my door. Dr. Evans, this patient's on home oxygen. They've called us 3 times this week. Their morphine has finished. Like, please, can you assist? And there'll be like a family phone number and an address and whatever. And I'll make a plan with community-based services, things like that. Our long-term goal is that we'll be able to link EMS directly with CBS so that, the CBS team could go to the house, check out what's going, those kind of things. But again, you can't expect EMS to leave the patient at the house with no care. So there was a problem. There was a problem because someone phoned an ambulance. Whatever that problem might be. Might not be an emergency problem, but there was a problem. But then it's all very fine and well to say, oh, you can't inappropriately take the patients to hospital. If your district hasn't created a way for EMS to arrive at the house, discover that this person doesn't need to go to hospital, who's going to help the patient? So in a lot of districts, the only way for the EMS crews to get the patient the help that they need is to take them to hospital. Because there's no one else to phone, there's no cat to leave a note under my office door. Granted, that's not exactly a foolproof system, but we're working in this space. And then obviously they're going to have to take to hospital. Because otherwise they're going to promise the family what? No one's going to phone you, no one's going to help you. You must just deal with this on your own. So I really do feel that proper systems need to be put into place in individual health districts that if EMS do end up at a house, this doesn't mean that we must now upskill all of EMS, every single EMS staff member to spend 2 hours at a patient's house. That's not appropriate. That's not appropriate usage of their time. They should be upskilled to recognize scenarios, and then they should be given the resources that they can refer patients onto an appropriate service that's not them.
One problem I often encounter is that if a palliative patient arrives at hospital due to reasons that we've spoken about, either a palliative care emergency, that's often a very simple need to be met. For example, pain relief or acute behavioral disturbances. Perhaps they just need a catheter or something like that. They've got urinary retention and now they can't pee. Patient arrives at hospital. There's a lot of people already waiting. EMS need to offload the patient onto a stretcher in the emergency unit. And then that whole process that could potentially take 5 minutes, if you recognize the situation early, have a quick chat with the family, establish what's going on, what's expected, what is needed at that time, often ends up into a 24-hour stint in the emergency unit because they're lying on a stretcher, and then transport home is an issue. And even if you've done everything perfectly on your side, you've put the catheter in, you've recognized what they need, that is a very prolonged, burdening situation for you, the family, for yourself, and for the unit.
Yeah, I think at the end of the day, this is a prevention is better than cure kind of situation. So again, when we're looking at management of the system, so I'm involved with our substructure palliative care sort of committee, and that's one of the big things that we're looking at, is that how do patients get help in an emergency when it is not an ambulance kind of emergency, let's put it that way. It's an urgent thing rather than an emergency. What is the mechanism for them to get help? And that is what each district team really needs to unpack. Is it, so for example, Cape Town is divided into 4, there's 4 different substructures or districts. And each team with their substructure group has to look at this exact thing. How do people get help that doesn't involve an ambulance and an emergency center?
With regards to, again, prevention, when it comes to old age homes and care facilities needing doctors' advice and attention, again, not necessarily for emergency situations, but often for urgent situations, a lot of them have access to GPs, they're linked to the clinics and day hospitals. A lot of the MOs go and do visits there. A lot of the family physicians look after old age homes. In acute situations, particularly at night and especially over weekends, we get a lot of referrals into our emergency unit for urgent situations from very frail geriatric patients. Is there a way that we can improve communication and offer after-hours advice, again, without them necessarily having to come into hospital? Because, again, they spend more time in hospital than they need to.
I think we've heard this from different views. We had a big engagement with a large frail care centre in our district where we were having lots of referrals in of patients that were very clearly at the end of their life. And again, this requires a district approach, not when there's a patient in front of you. So this requires in the light of day, less emotive, not with a patient in front of you conversation to discuss these things in advance. So we had some engagement with this big center where they have almost 100 bed-bound patients. And we managed to come to some realizations that there are problems on both sides. So you get sent home from hospital with a very generic discharge letter. It doesn't really say much. It's not meat to it. It's just sort of medical words, blood results, x-ray results, scan results. The plan says follow up CHC 2 weeks. That's the whole future plan. Like there's even a heading that says like future management plan. So we had some engagements, and the one senior manager of this frail care center, who is a non-medical person, but she is the senior manager. There's obviously a nurse manager and everything else, but she is the senior overall, I think maybe CEO or whatever. And she said, her side of things, it was interesting to get the other viewpoint, is that she deals with unhappy families who have complained because they come to visit and no one's doing anything, or they're like, but what's, what have you done? What are you doing? What's going on here? Why is he not at hospital? That kind of thing. And then they know, says, me as a non-medical person, I also know that someone like this, it's okay for them to pass away at the old age home. They don't need to go to hospital. But she said it's very difficult for her as a non-medical person to communicate that with family who are upset. But she said what really helps her is that for our patients, because some of the patients from our facility would come with a comprehensive discharge letter with proper future management plans, that so for simple wound care, not for advanced wound care, wouldn't be for surgical debridement. The focus of care or the goals of care is to keep her as comfortable as possible, avoid future hospital visits. If showing signs that is at end of life, to give this med, that med, family counseling, involve the relevant spiritual leader from that family's group and whatever. And when she said that she would read that as a non-medical person, when these patients would come back from us, the few patients that came with it, not to say that we're perfect or every patient came home with one of those. And she says that was really helpful because often the family never comes to hospital, or they if the person's in and out of hospital within a day and a half, the family member just gets the news that their loved one's at hospital and then they're back at the old age home. And then they've got lots of questions that the old age home staff find difficult to answer. But when the discharge letters are appropriately written, then it actually gives her, as the owner of the CEO of the old age home, almost permission to keep Granny here. Instead of feeling obliged to phone an ambulance, or the nurses feeling like they're supposed to because they're going to get into trouble if they don't. And I thought that was a really interesting perspective. And once I heard it from their side, I'm like, we need to up our game. The other thing that happens is sometimes the family's counseled really well, but the old age home staff are not. But again, it's about relationship building. And it sounds really boring, and I don't have magical medical solutions, but it just look at where you work. What is your district? What are your old age homes? Who holds that space? Who has those conversations when there isn't a patient? This is the concept of advanced care planning. That's what it is. It's advanced care planning, which is a big component of palliative care, is looking at when certain things in the future occur or might occur, what are we going to do? And it blows my mind that you can have old age homes with 100 bed-bound people and they can have no advanced care plans. So I think this is area in South African government sector palliative care that we really need to look at, is improving the amount of advanced care, how we do advanced care planning that is acceptable to our patients. And this is something that is definitely not done adequately. But also understanding that this is not some palliative care fairy that's going to come and do this for you. Is that advanced care planning needs to be in how we do things as hospital-based clinicians.
To continue that thought in terms of recognition of palliative care needs, with the old age home staff being empowered by good communication to make those decisions. For doctors in South Africa, are there tools or resources that we can use to help us recognize and guide palliative care approaches? In a lot of places, advanced workups such as CT scans and biopsies are often difficult to get in the first place, and one also waits a long time for them. But you might realize at the beginning that whatever is going on is likely to be advanced in any case, so a palliative care approach would be better from the start. What can we use to help us make that decision?
Yeah, so there's a consensus tool called SPICT SA, which is the South African version of the supportive indications for palliative care tool. And I'm sure we can link to it in the show notes. That is the consensus tool of which patients meet criteria in our setting for a palliative care approach. Now, very important, this is that whole image of there's the curative care and palliative care graph, which again we can probably link to. And these things can exist in parallel to each other. It's a very great tool. It divides things down based on systems, but also based on frailty. and non-clinical indicators. Then there's also consideration in general, and there's not a beautiful tool for it, but I do quite like the clinical frailty score as a general thing. It might exclude certain groups, it might not quite work for people with disabilities like paraplegics, etc., but in general, the clinical frailty score is quite helpful. It just helps you to really understand where your patient is. And you've always got to think as a hospital-based clinician, okay, I'm going to do certain tests. I'm going to do a cancer workup. You've always got to think is, what is the purpose of this? Any test to do. I mean, this is just a general rule in healthcare, right? This is not necessarily related to palliative care or emergency care, but if you're not going to act on the test result, why are you doing the test? It's very important to engage your patient and families in these things, but not just be like, oh, do you want us to do the test or not? It's like, okay, so if the test shows this, this is what we'll do with that information. If the test shows Y, this is what we'll do with the information. And using that clinical frailty score, it's not a score. It's not like above this number, do this, below this number, do this. I think it just helps junior clinicians to wrap their head around and actually force junior clinicians to actually ask the questions about baseline comprehensively and not just say poor baseline, good baseline. People are like, oh, no, we'll do the test and then we'll talk to the family afterwards. There's a hell of a lot of families that don't know the reason they're having the test is we think it's cancer. And that's quite tragic. And you just presumed that someone had told them that the reason we're doing the CT scan is because we're worried that you might have cancer in your lung. And they're just being told you need a CT scan because of this pain that you're having. There's some patients that when you tell them, oh, the reason you're coming for the CT scan is to look for cancer, that the patient themselves with no prompting is like, oh, no, I don't want to go through. Or, no, if you're saying this is probably cancer, I'm not interested, especially the elderly. Some of the elderly, it's only the doctors that are uncomfortable with this, like not doing investigations. But when you actually put it to the patient, a lot of them are like, oh, absolutely not interested in that. Thank you very much. Moving on. And then it's like, oh, okay. Well, that was easier than what I thought.
Last question. If you had a magic wand and you could wish for anything tangible, obviously topical in terms of palliative care and healthcare in South Africa, what would you wish for to materialize now?
I don't know if I can choose one thing, but I'll maybe try and drag this till two. Okay, there's the obvious one that's boring. You're going to yawn. It's like whatever. Obviously, funding. I saw a social media post or something in the last week or two where it's like no other discipline involved in like core care of patients needs to sort of run bake sales and sell secondhand clothing to get money to, I think the quote was, to pay for the patient to have an appendectomy. I mean,
that's deemed completely necessary by our healthcare system.
Yeah, a completely like core part of healthcare that's like not an optional extra. It's like fundamental sort of right. And yet they sort of have to do weird and wonderful fundraising. An understanding of that. But I say that, but at the same time, I think the Western Cape government is really taking huge strides in this. I mean, we already see this with the creation of 18 palliative care posts across the province for professional nurses. So there is that slow culture change. But at the same time, my other side of this, my magic wand, what magic wand would I want? What one thing is a fundamental understanding that a palliative care approach is not something that someone else comes from somewhere else and does for your patient. Like it is the way we need to integrate this in our service is our basic palliative care. I hope, my hope is that the way that our undergraduate curriculum is changing and integrating palliative care into the state sector and letting the students see examples of palliative care integrated into our system, like the Heidevelds of the world, instead of it being trained as something that people do somewhere in hospices. Like the way our medical students are learning these things will change the culture of how things over the next 20 years as that generation of ex-medical students grow up in the system, how we approach scenarios. But at the same time, without taking away from the fact that advanced palliative care, specialized clinicians, whether that's doctors, nurses, social workers, etc., are still required, but that shouldn't be for the everyday patient that has palliative care needs or the need for a palliative care approach. So that's my hope.
Awesome. Well, thanks so much for joining us on the podcast. Well, partly your podcast. But yeah, thanks for your wise words, and I'm sure we'll see you again in the future.
Cool. Thanks so much, Dan. Thanks.
All right, that's all for this month's episode. I hope you found it as interesting as I did. Just to recap, Callum from the case report spoke to Kat about what palliative care is with regard to emergency medicine and hospital-based medicine. Then we spoke about cost saving, communication with families and old age homes, how prevention is better than cure in terms of appropriate needs-based service delivery. And then we ended off by chatting about how we can apply these principles wherever we work. One thing we ran out of time for was how to further your knowledge and qualifications in palliative care in South Africa. And there are many options. Two big groups are the APCC, which is the Association of Palliative Care Centres, and PALPRAC, which is the Association of Palliative Care Practitioners of South Africa, which have lots of great content and resources as well as ongoing educational opportunities. I've linked their websites, as well as some other links of further diplomas and certificates from various universities and other organizations that any healthcare providers in South Africa can do, regardless of what field you practice in. As always, please like and subscribe on all of your main platforms and share with your friends and colleagues. If you would like to get in touch, please send me an email on dan@badem.co.za, and please visit our website www.badem.co.za for more content. Thanks for listening. Bye bye.